Welcome back to the deep dive. We are starting today with a psychological paradox, one of those deeply human knots that sits right at the intersection of intimacy and, well, profound fear.
Mm.
Think about this. What if the most intense, urgent, or even seemingly compulsive sexual behavior you observe, or, on the flip side, a complete and total sexual shutdown, isn't actually about desire or pleasure or love at all?
Yeah, a lot of the time it's not. What we're investigating today is a profound unconscious survival strategy.
It's a survival strategy.
Absolutely. It's deeply rooted in past trauma,
Oh.
specifically early or prolonged interpersonal violence, and it radically hijacks the core human experience of sexuality. The nervous system, prioritizes survival over everything else,
Over connection, even.
over everything.
So that's the mission. We're taking a deep dive into the complex psychological and, the neurobiological landscape where severe trauma collides with sex and intimacy.
Right. And we need to move well beyond just saying trauma causes distress.
It's so much deeper than that.
It is. Our goal is to investigate the fundamental reorganization of the brain that forces the mind to prioritize predictability and control and immediate safety.
Above the capacity for genuine pleasure and vulnerability.
Exactly. We need to understand how the nervous system, once it's been fundamentally compromised, reframes basic human connection and even healthy arousal as a potential threat.
And that reframing shows up in diagnoses like PTSD.
And more importantly for our talk today, in complex PTSD, this entire discussion is about understanding the root mechanisms, the neurological wiring. It's not about judging the behavior that comes out of it.
Okay, let's unpack the history first, because this connection between early trauma and emotional distress, it's not a new idea, is it?
Not at all.
Yeah.
The medical community actually stumbled upon this way back in the late 19th century.
Before we even use the word trauma, like we do today.
Right. We have to acknowledge this really early and very controversial recognition that traumatic, especially sexual experiences, were at the root of what they were calling hysteria.
Hysteria. So we're talking late 1800s. Figures like Sigmund Freud.
Exactly. He observed that many of his patients, particularly women with these severe, baffling physical and emotional symptoms, they had a history rooted in traumatic experiences, often sexual abuse in childhood.
So what was his first theory? What did he initially conclude?
He developed what he called the seduction theory. He
Ah.
basically theorized that these early sexual traumas were the real origin of the chronic distress, the mysterious physical symptoms that had no organic cause.
That sounds radical for the time, suggesting it was an external event, the abuse causing the internal illness.
He was a massive departure. He documented cases, often involving abuse by authority figures, family members.
And here's where it gets really dark. That insight was almost immediately suppressed, wasn't it?
It was a quick and devastating minimizing of a core truth. It was rejected because of these intense societal taboos around childhood sexuality and the explosive idea that fathers or respected men could be perpetrators.
So when he presented this, his peers just shut it down.
Fierce protest, outright denial. It was socially and scientifically just unacceptable.
So facing that pushback, what did he do?
He made a catastrophic reversal. He basically backtracked, reframing the accounts of abuse he'd heard as products of his patient's internal fantasies.
Wow. So he shifted the blame back onto the patient.
He did. And that allowed him to introduce concepts like the Oedipus complex. But that retraction meant that the significance of real early sexual trauma was just systematically minimized for decades in psychological research.
The scientific community just breathed a sigh of relief and looked away.
Pretty much.
And
And once that door was closed, the focus shifted entirely away from that kind of interpersonal trauma
so where did they look instead?
to things they couldn't ignore. Major disasters and, most significantly, the massive repeated carnage of World War I and II.
That's where we get terms like shell shock.
Exactly. Shell shock, Kriegszitterung. The focus was on the psychological injury from a sudden massive assault on the senses.
And the symptoms they described. Hyperarousal, nightmares, irritability, social withdrawal. They sound incredibly familiar.
They're precisely what we discussed today. But the historical context is jarring. These soldiers were often treated as moral failures, as malingerers, or cowards.
The treatments were barbaric, weren't they? Things like electrical shock therapy?
Veritization, yes, trying to literally shock the perceived moral failure out of them. It's crucial we carry that weight, the cost of misunderstanding trauma, as we move forward.
It wasn't really until the 1940s, with people like the American psychoanalyst Abram Gardner, that a more humane understanding started to form.
Right. Gardner worked with World War I veterans. and he theorized a psychobiological background to it. He suggested the mind and body were fundamentally injured together. He called it physioneurosis.
And what was his core idea?
He surmised that the patient acts as if the actual traumatic situation still existed. They're constantly searching for protective measures that weren't there during the actual event.
So he saw that the person's entire operating system had been changed, not just their memories.
Exactly. The body and mind are locked in a continuous state of preparing for a threat that's already passed.
Okay, let's fast forward to the 1980s. This is when the official recognition finally catches up.
The formal establishment of post-traumatic stress disorder, PTSD, with the DSM-3 in 1980, this is a huge validating step.
And it defined the diagnosis with those concrete symptom clusters, right? Intrusion, avoidance.
Intrusion, avoidance, and hyperarousal, yes. But the definition was largely built on observations following time-limited events.
Like combat or a car accident.
Exactly. And the research that followed, especially with survivors of chronic, prolonged abuse, showed that this simple event-based model just didn't capture the whole picture.
It fell short.
Drastically. Chronic, repeated, and especially early-life interpersonal trauma violence from the people supposed to protect you causes a much broader, more complex set of symptoms.
Things beyond just flashbacks.
Way beyond. Severe difficulties with affect regulation, self-image problems, self-harm, sleep disorders, chronic relationship issues, and crucially, pervasive sexual disturbances.
Which brings us to the critical distinction: complex PTSD. CPTSD.
CPTSD is the essential framework for this deep dive. Unlike simple PTSD, CPTSD highlights the extensive systemic damage across multiple areas of a person's life.
So what are those areas? What does it look like?
Well, there are 7 critical areas. First, you have difficulties in affect and impulse regulation.
Yeah.
So, persistent anger, self-destructive impulses.
Okay.
Second, distortions in self-perception.
Yeah.
Feelings of being permanently damaged, deep shame, hopelessness.
Right.
Third, disturbances in relationships. This is huge. An inability to trust, swinging between withdrawal and desperate dependency.
Fourth is somatization, which is...
Physical complaints with no known medical cause.
Yeah.
The body is holding the stress.
Okay. What else?
Fifth, changes in systems of meaning. A loss of faith, deep despair about the world. Sixth is alterations in attention or consciousness. That's dissociation, which we'll get into. And finally, difficulties with perpetrator identification.
Yep.
Sometimes even idealizing the abuser.
That list, it shows CPTSD isn't just a memory disorder. It's a total reorganization of the personality around betrayal.
That's the perfect way to say it. It's not about what happened, but about who the person became because of it.
And the risk is higher the earlier it happens and the longer it goes on.
A clear dose-response relationship. The nervous system is effectively molded by violence during those key developmental years.
So let's talk numbers. How common is this kind of trauma?
The numbers are alarmingly high. Some U.S. studies report lifetime exposure to traumatizing events up to nearly 90%.
To 90%.
But the type of trauma matters profoundly. Intentional, interpersonal traumas, the ones willfully inflicted by another human, are significantly more likely to lead to long-term pathology than, say, an accident.
Because it shatters your fundamental trust in people.
It shatters the assumption that the world is a safe place. That betrayal is uniquely destabilizing.
And we need to be clear, it's not just about sexual abuse. Emotional and physical abuse, neglect, they're also highly consequential.
Absolutely. Emotional violence and neglect can severely disrupt a child's ability to form a secure bond with their caregivers. That bond is the template for all future relationships.
And when it's corrupted.
In later life, it manifests as chronic anxiety, deep distrust, social withdrawal. These constant, painful tension states. Even non-sexual trauma compromises the underlying capacity for safety and intimacy.
Which inevitably hits sexual health down the line.
Inevitably.
So let's move from the psychological description to the actual physical changes in the brain, the scar upon cerebral tissue, as William James put it.
We can now scientifically confirm that. Trauma doesn't just live in memory, it fundamentally changes the nervous system and the architecture of the brain, especially when it happens in childhood.
It can permanently damage those developing structures.
It leads to an organic fixation of the trauma. These are measurable changes in brain structure, function, and endocrine systems that persist well into adulthood.
So let's map out that scar. How does the brain physically reorganize itself into permanent survival mode? Let's start.
We start with the amygdala. It's the brain's deep, ancient emotional core and its nonstop threat detection system.
Okay.
In a traumatized individual, the amygdala becomes hypersensitive. It's permanently set to maximum sensitivity. It takes in all sensory input, and assesses danger based on past trauma.
So starts firing false alarms.
Constantly, even in response to neutral or non-threatening stimuli. This explains the hair trigger response, the constant jumpiness, the feeling that danger is always just around the corner.
Even when rationally you know you're safe?
Exactly. This amygdala hyperreactivity immediately triggers exaggerated stress responses. The body is constantly poised for fight, flight, or freeze.
And what does that do to the body's main stress system, the HPA axis?
It becomes profoundly dysregulated. The amygdala's constant alarm signal triggers the excessive chronic release of CRH, corticotropin-releasing hormone.
And CRH is like the master switch for the body's stress factory.
That's a great analogy. It's the ignition key.
Yeah.
And that key is constantly turned, even when the engine should be idle.
So the body is locked into a state of high stress readiness.
Precisely. You see measurable consequences. A persistently increased heart rate, an exaggerated startle response, chronically elevated levels of stress hormones like noradrenaline and adrenaline.
And that causes systemic wear and tear. I think I've heard the term allostatic load.
That's exactly what it is. It's the cumulative burden of chronic high stress. Think of it like redlining the engine of a car every single day for years.
Eventually, things start to break down.
The engine begins to fail in complex ways. This is why traumatized individuals often have increased vulnerability, not just to mental illness, but to chronic physical conditions like autoimmune disorders or chronic pain. The body just wears out.
But this chronic stress also creates a costly cognitive trade-off with memory, right?
It does. The brain is optimizing for survival, but at the expense of rational thought. The stress hormones are really good at one thing: enhancing the consolidation of emotional memory.
So it makes the traumatic events intensely memorable.
Deeply, persistently memorable, often stored in fragmented sensory chunks. A smell, a sound, a feeling of paralysis, not a coherent story.
But that efficiency comes at a cost.
A devastating cost. At the same time, those same hormones impair other functions, specifically working memory and the retrieval of non-emotional, neutral information. The person's mental bandwidth is permanently dedicated to threat assessment.
And we can see this physically in the brain.
We can. Structural imaging often shows a significant volume reduction in the hippocampus in traumatized adults.
The part of the brain for memory and context.
Exactly. And the hypothesis is that the chronic presence of high-stress hormones during developmental years just inhibits the normal growth of this critical structure.
So we have the amygdala overfiring, the hippocampus shrinking, and then there's the brain's regulatory system, the control tower, the loss of the brakes.
Right. The medial prefrontal cortex, or MPFC.
Yeah.
In a healthy person, the MPFC is the brake pedal. It allows for self-regulation. It helps extinguish fear responses once the threat is gone. It's the part that says, okay, that was just a car backfiring. You can relax.
But in CPTSD, that brake line is cut.
It's compromised. The inhibitory mechanism fails. And that leads directly to chronic anxiety, a reduced ability to self-regulate emotions, and a profound difficulty in turning off the fear response.
So a minor disagreement can feel like an existential threat.
Absolutely. The nervous system can't modulate the intensity of the reaction. It's an instant high-stakes emotional emergency.
And this even shows up in how people communicate or struggle to communicate the trauma.
The neurobiology explains this devastatingly well. When someone tries to recall a traumatic memory, you see increased blood flow to the amygdala, the fear center. But at the same time, you see reduced blood flow in Broca's region.
The part of the brain for speech.
For speech production. The cognitive capacity to verbalize the experience literally shuts down. They're not being resistant in therapy. They're facing a biological wall.
When you lay it all out like that, this reorganized brain, wired for survival, it's no wonder that sexuality becomes so problematic.
Right. Sexuality inherently requires vulnerability, trust, a feeling of safety, all the things that have been compromised.
But here's the hurdle. Addressing these issues in therapy is still often avoided.
It's a criminally undertreated area. There's a legitimate fear for the patient and the therapist of triggering dissociation or re-traumatization. And often the more visible symptoms, depression, anxiety, take priority.
Which is tragic because sexual dysfunction is incredibly common in CPTSD, like more than 3 out of 4 people.
The numbers are staggering. And these problems exist across a dramatic, often contradictory spectrum, a stark polarity between what we call hyposexuality and hypersexuality.
2 sides of the same survival coin.
Exactly. Avoidance or engagement, but both are driven by the same underlying fear.
Okay, so let's define those poles. Hyposexuality.
Hyposexuality is what you might expect. It's low or absent desire, intense sexual aversion, avoiding intimacy, or just painfully enduring it.
The body's saying, stop, this is overwhelming.
Right. It's an effort to avoid any bodily arousal or intense sensation that feels uncontrollable or too similar to the original trauma.
And then you have the opposite, hypersexuality, which is so often misunderstood.
Drastically misunderstood. It's characterized by increased, often compulsive or risky sexual behavior. Impulsive sex, uncommitted partners, using sex as a form of self-medication.
But, and this is the core paradox we started with, it's frequently not motivated by pleasure or desire.
It's not. It is an intensely desperate mechanism for emotional regulation and safety management.
So it looks like high desire, but it functions as an emotional shield, like armor.
It is absolute armor. The brain is desperately seeking predictability and control, and it uses the sexual act to avoid internal chaos.
What kind of chaos?
Feelings of deep emptiness, chronic shame, paralyzing anxiety, fear of rejection. The internal dialogue, which is rarely conscious, is something like, I am feeling overwhelming dread, and the only thing that distracts me is this intense, predictable engagement.
Or if I control this situation, even if it's painful, at least I have the illusion of agency.
Precisely. The brain chooses the familiar, predictable discomfort of the behavior over the unpredictable, overwhelming discomfort of the internal feeling.
So saying yes can actually feel safer than saying no.
Yes. Saying no risks, conflict, rejection, anger from a partner, which can feel like acute danger to a hypervigilant nervous system. The internal logic is, I will preempt the danger, I'll decide the terms.
It's a tragic attempt to rewrite the script of powerlessness.
And because the root need for safety is never met, the behavior often feels empty and leads to intense shame afterward, perpetuating the cycle.
And this compromised capacity for choice leads to a devastating pattern: re-victimization.
This is one of the most critical and tragic findings. Early sexual trauma, child sexual abuse, is a significant, measurable risk factor for subsequent sexual violence in adulthood.
So the trauma itself creates vulnerabilities that can unconsciously draw people back into harmful situations. How?
There are a few mechanisms. One is an unconscious scripting, seeking what's familiar. Even if it's painful, it's a script the brain knows how to survive.
Right.
There's also deep-seated self-blame and low self-worth, which makes it harder to advocate for safety or set boundaries. And then the body's trauma response itself, like freezing, can kick in and inhibit self-protection.
So the survival mechanisms designed for the original trauma paradoxically increase risk later on.
And the data shows this. People who experience both childhood and adult sexual abuse show significantly more severe sexual problems across the board. The damage just compounds.
Okay, we've established this brain is hyper-alert, managing overwhelming distress. But there's a key internal mechanism that makes it all possible, especially during intimacy: dissociation.
Dissociation is the ultimate coping mechanism. It's a mental disconnect. When you can't physically flee or fight, you use the psychological escape hatch.
You check out.
You check out. You feel profoundly detached from your body or the experience.
And this would be especially pronounced in diagnoses like borderline personality disorder or BPD, which has such a high overlap with trauma histories.
It is. And recent clinical research comparing women with BPD to healthy controls shows some really stark findings.
Okay.
BPD patients report significantly higher dissociation in sexual situations.
And this isn't just them remembering it later.
No, this was observed even in controlled settings, like after exposure to erotic stimulation. The mere anticipation of intimacy is enough to activate the defensive dissociative response.
And the key thing here is that dissociation isn't one single thing. The research breaks it down.
This is the most complex and important detail. The studies looked at 3 specific subtypes: depersonalization, derealization, and conversion. And they found that the factors driving each one were distinct.
Okay, let's start with depersonalization.
Depersonalization is the feeling of detachment from yourself, feeling unreal, observing your own body from the outside, feeling emotionally numb.
Like you're an automaton.
Exactly. Then you have conversion symptoms, which are unexplained physical things, like profound numbness or paralysis with no medical cause.
And the research found that those two, depersonalization and conversion,
Were primarily explained by the overall severity of the BPD symptoms. They're tied to the core difficulties with self-experience and regulation that characterize BPD.
okay, but then there's the third type, derealization, and that's different.
Completely different origin. Derealization is the feeling of detachment from the environment. The world feels unreal, dreamlike, foggy. The room, the partner, the context feels distant, like you're watching a movie.
And what explained the severity of derealization?
The presence and severity of PTSD symptoms.
That is a profoundly powerful insight. So the environment fading away is tied directly to the processing of the specific traumatic event itself.
Yes. Depersonalization says, I am not real. Derealization says, the world is not real. It connects the acute trauma-specific response to how the patient experiences their physical environment in moments of vulnerability.
And there's a counterintuitive finding about emotions, too. It wasn't just negative emotions that triggered dissociation in BPD patients.
This really challenged core assumptions. For BPD patients, the intensity of almost all assessed emotions, including positive ones like curiosity and even sexual arousal, correlated positively with dissociation.
Wait, hold on. You're saying the onset of sexual arousal, a potentially pleasurable state, can actively trigger dissociation?
It does. It points to a generalized tendency to perceive intense emotional experience of any kind as stressful and overwhelming. The body has been trained by trauma to avoid high arousal states, so even healthy curiosity or excitement triggers the defensive shutdown
The system prioritizes emotional avoidance over genuine experience.
because it's learned that intense sensation equals overwhelming danger.
Okay, so let's connect the dots between dissociation and those high-risk sexual behaviors. We know BPD patients engage in more impulsive sex. How does the specific type of dissociation drive that risk?
This is where the distinction becomes crucial for treatment. The research isolated the specific factor that predicts this risky behavior,
And it was.
derealization. The feeling of detachment from the environment was the strongest predictor of engaging in uncommitted and impulsive sexual behavior.
Why?
Think about the psychological barrier this removes. When the physical environment, your partner, the context feels unreal, the psychological boundaries that normally protect you are just eroded.
It's easier to engage in high-risk acts if the reality of the situation is filtered as not real.
Exactly. The disembodiment facilitates the risk-taking. If you're watching a movie of your life, the stakes feel lower.
What about conversion symptoms? They had a surprising, almost inverse relationship.
This is a fascinating clinical nuance. Conversion symptoms, that physical numbness or paralysis, showed an inverse association with impulsive sex.
So they might be protective, in a way.
We can speculate that this physical avoidance, the body literally shutting down, might function as a subtle protective factor. The immediate physical shutdown, though distressing, might enforce a boundary that prevents the high-risk act from happening.
So avoidance in this physical form might reduce external risk, even if it causes internal distress.
It might. And this level of detail completely changes how you have to approach treatment. You have to move past generalized trauma-informed care.
Which brings us to the treatment gap. Why isn't standard PTSD therapy enough?
Because the research confirms that successfully treating PTSD symptoms reducing flashbacks, hyperarousal often fails to resolve the chronic sexual symptoms.
So you can stabilize the trauma memory, but the learned mechanisms of sexual dysfunction, the dissociation, they remain.
They're deeply ingrained functional problems that require dedicated, direct intervention. You have to bring trauma therapy and sexual therapy together into one integrated model.
So what does a program like that look like? What are the core components?
The focus shifts entirely to rebuilding the connection to the body and establishing agency and choice. So you start with rigorous psychoeducation about the neurobiology, how the amygdala is sabotaging intimacy. Then you move into intensive training and self-soothing strategies.
Give us an example of a self-soothing strategy in this context.
Okay, so when a patient feels that onset of high tension that triggers the dissociative alarm, they're taught immediate grounding techniques.
Like what?
It could be using a scent anchor, a specific, safe, neutral smell, or specific breathing exercises to regulate the vagus nerve, or tactile strategies, like gripping a piece of cool metal. The goal is to interrupt the dissociative flame response and promote grounded presence.
Reminding the body, you are here, you are safe, this is real.
Precisely. And then there's the relational side. Explicit work on boundary setting, communication, learning how to say what you need or want without it feeling like a threat.
And rebuilding a sexuality that's separate from survival.
Exactly. Learning the difference between I should do this and I want to do this.
So if derealization is the big driver of risk, what does treatment look like there?
You focus specifically on techniques that promote anchoring to reality during intimacy. This is where those grounding techniques are paramount. If you can help the patient feel viscerally anchored in the physical environment, feeling safe and real, you directly reduce the mental escape hatch that facilitates risky behavior.
So you're moving from chronic automatic reaction to a place of conscious choice.
That is the ultimate objective. To support the shift from using sex as armor or escape back toward experiencing it as a chosen act of vulnerability or intimacy or pleasure.
We've covered a tremendous amount of ground here, from the historical denial of trauma through the neurobiological hijacking of the safety system, right into the nuanced mechanisms of dissociation that drive risk.
And it fundamentally changes our perspective. What looks like a simple behavior, hypersexual or avoidant, is actually the complex expression of a reorganized brain operating under the constant perception of mortal threat.
And understanding the distinct roles of derealization versus depersonalization is the key to unlocking treatment.
It's the key to targeting the function of the behavior, not just the behavior itself.
The journey here is about finding the space between that survival response and the capacity for genuine connection. For you, the listener, who may be processing this, remember that this complex array of symptoms is proof not of weakness, but of the immense creative power of the brain to survive impossible circumstances.
It made sense then.
It just doesn't serve you now. The takeaway here isn't just theory. It's permission to realize that if you're struggling with this, you aren't broken. You're simply operating on outdated survival software, and that software can be updated.
And that leads us to the final thought. If the root of these symptoms is a desperate need for safety and control, then the goal of healing is not to force desire back into existence. The real objective is to reclaim self-determination.
The ability to pause.
The ability to pause, to choose stillness, to choose slowness, and to finally truly separate the frantic need to survive from the inherent capacity for unburdened intimacy. The beginning of true healing often starts with that quiet, internal question.
Do I really want this right now, or am I just trying to stop the feeling of dread?
When you can hear the difference, you can finally begin to choose peace over performance.
That's a powerful place to end today's deep dive. We hope this exploration gives you not only new knowledge, but a profound shift in perspective.